Yeah, so this is my fellow put this together, and I tell him to take out the orthopedic stuff and just put some stuff for your running. So I'm not sure what was in there, but this is, you can't see this. No, it's not going through. This is just showing the same thing that I was doing, how we do it. Oh, here it is. Here it is. So you basically, sort of a strange speed here. You have to undermine all this tissue, which can cause wound problems a little bit sometimes. It's not too bad. And that's supposed to show you how to pull things up and down to see different parts through a small incision. It's like a parlor trick. Some of these things are parlor tricks. But you can see you can get your resurfacing through a very small incision. Now, I don't have to do this if I just make it here to here. And most men it's about 3.5 inches, and I think women are 4.5 to 5. And I'm getting smaller, so not everything is better if it's bigger. What? What was that?
That's you on pre-op.
Yeah, that's You don't want your surgeon to not see what they're doing. That's the key. The incision should be, and actually I do feel strongly about that. The incision should be exactly what you need to do your procedure. No more, no less. You better be able to see everything, get the bleeders. That's what you want. Okay, there are parlor tricks, and it's great when 9 in a row do great with this little micro incision, but when that 10th one has a problem, you forget about the 9. I mean, in fact, I can have 99 successes. I'll have 99 in a row and have one person that's a failure, and that's all I think about. It's very depressing, but it's true. You're only as good as your last case. So these are pretty small incisions, and here, that's 3 inches long through a resurfacing, because you're really just poking out the head. And what we found is there was no difference. I could do them as fast, but really minimal difference between the two. Okay, so let's get to the crux of this. Now, if there's any one slide that has everything that I think you should know, it's this and then the disadvantages slide. This is what you want to do whenever you're thinking about anything in life. Think about the advantages and the disadvantages. Okay? We talked about number 1, the conservative on the femoral side. Visually, that's an important thing, but if this is not going to get you a better result, then you don't want conservative on the femoral side. So assuming they're the same, that's a nice thing to have the device that's being passed around versus a whole hip replacement. Lower dislocation rate, that's theoretical because there's a large head. The head that we're using matches the head that you have to the within a millimeter or two. Typical hip replacements have small heads. Oh, if I'm in the way, I'm sorry. Typical hip replacements have small heads, like 30 millimeters, 32 millimeters. Typical women have heads that range from 40 to 48 millimeters. And men overlap, so 40 to 48, and men are something like 46 to 54. That's just the way the anatomy is. So you can see that even those numbers are larger than the typical hip replacements, which are 26, 28, 32 millimeters. Now they're getting a little bit larger. Because they're larger, yes.
When you're talking in terms of that, does that mean that you don't have just one size of those things, that you've got a lot of different sizes?
I have to always count, but we have at least 9 or 10. So we have 36, 38, 40, 42, 40. 10 sizes, unless I need a custom. If I need a custom, I know it. I see they're too small. Sometimes if you're too small, you just can't get a resurfacing because there's not enough material. It wouldn't be good for you. That would be one of those you need to see the x-ray. And sometimes you're too large. I've done this on 6'7", 6'8", and 6'10", but I also missed a 6'8" because his bone was too large. So I've done, and those were tough. But and 1 or 2 of those were customs.
So when you do the surgery, you don't know what size until you get in there and measure, right? So do you just have a slew of those devices in front of you so you know which one to pick?
Okay, excellent question. I can have a general idea what size by templating, but depending on, so you put somebody's x-ray up and you know that the x-rays are magnified by about 20%. but they could be magnified 10% or 30% depending on how heavy the patient is or how far away they were from the cassette. So unless you do these very rigorous scientific things like putting a special block, you're never 100% sure what size you're going to use in the case. So and also there's other reasons in the middle of the case why you might change your size by 1 in both directions. You need to get a stable hip. You don't want to make somebody longer. Things like that. You don't want to make somebody shorter. You don't want to sacrifice something. So you really don't know for sure what size till you're in the OR. What you're doing is you have these reamers that allow for 10 or 11 sizes, so 9 to 11 depending on the situation if you need a custom. And you're molding it depending on everything you're looking at during the case. And I guess there could be another, we're not going to do that today, but maybe another time if somebody really wants to see the procedure. I usually don't want people to see every detail of the procedure until they're past their hip surgery 6 months. You know, Charlotte's had a hip replacement, she's feeling great. She wants to see a video of how I do this to the nuance. I think it's appropriate now. I don't think it's totally appropriate to show every little detail to somebody thinking about it. You know, I wouldn't even want to do that. If I'm thinking about getting a procedure and I do them, I wouldn't want to see all the nuances of some, if I needed a urological procedure or a GI procedure or something. It's just, I don't think that's right. But I do show patients they can get discs of my surgery 6 months or a year down the line. And I guess other patients want to see this to the detail. But anyway, to answer the question, we have capability of milling all these different sizes, and then in the OR you have in boxes all the different sizes available. So you should not start the case until you have everything ready for you, because you don't know which way. But you usually can tell within, you know, 1 or 2 from the x-rays ahead of time, but you got to do the last minute fine tuning. Yes.
Besides x-ray diagnosis, is there cases where you would recommend an MRI or CAT scan?
No, not at all. Patients ask me this all the time. Oh, I tell them, you know, you're a 90% chance, I think I can do this because you got a little cyst here, or you're only a 50-50. Is there an MRI? Is there a CT that I can do to help you make the decision? No, in some cases, maybe the answer is yes. In most cases, no. The real answer is, if you need a hip replacement, you've got to go in there, because a CT or an MRI could show bone, and I can go into the case, and there's bone, but I put my finger through it. It's like Jell-O. Just because there's bone there doesn't mean it's hard enough to support a prosthesis. So you have to actually look and feel and see where the bone is and see the anatomy. So people come in with 5 different tests, and it's just a waste of time.
So those tests do not show like a necrosis or something?
Certain things do show necrosis, but remember, anybody with arthritis has areas of necrosis, of dead bone. And then I get all these patients, oh, I have avascular necrosis. You don't have avascular necrosis. You just have a little area there that's avascular necrosis, and they're sent to me because I'm supposedly an expert on avascular necrosis. No, you have osteoarthritis. That's what your disease is. It's involving both of your joints. And there's a few areas where there's dead bone because you've been walking on a hip that's arthritic, and areas die a little bit. So in some situations, true avascular necrosis, if somebody's, you know, there are situations where you would want to get an MRI or a CT scan, but very, very rarely. I don't need that. Simple x-rays will show it, and it takes a very brief moment to be able to see what you need to do. They need to be decent x-rays. They can't be out of focus. Now, so getting back to lower dislocation rates, that's theoretical because it's a large head. Well, it turns out, I told you I've done over 1,000. I've had 0 dislocations. And I really, and most of the people, some people have dislocated resurfacing. That doesn't mean the whole field. Yes, knock on wood. Every time you say something, you jinx yourself. So
Yeah.
I don't know, it'd be funny. I'll have 2 next week. No, I can say that with confidence. I don't expect to get a dislocation. These are stable. They're almost as stable as my hip, as far as I'm concerned. When I leave that OR, I got them stable. Yes.
What kind of activities are these people doing?
We're going to get to that. Let me. You're going to see a few slides of some activity, and then if I don't answer that question, put your hand up again. Let's get to it afterwards. I'm going to talk about activity as a separate issue. I want to get through the advantages and disadvantages, and I have some dichotomies of what you're going to hear, how I feel about activity, and some of what I remember. Another thing is, just remember, a lot of what I'm telling you is my opinion. Okay, and especially when we talk about activity, you're going to hear my philosophy. Other people may disagree with that. I'm going to try to tell you what's fact and what's opinion. Okay, and try to separate that. Okay, I'm trying to tell you this is an opinion, this is a theoretical advantage, this is a real advantage. Yes?
I've had some debates with my local orthopedic surgeon who's pro THR, and he threw something out, the complication rate. Is that some valid measure of THR that can be compared for service hip? And he gave it, he threw a number out, 22%. I don't know where that was
his
coming
number
from.
comes from me. And I'm going to show, I think I'm going to show it to you.
Okay.
Okay, you're going to see a 22% rate in the first group of 50. We didn't know it was 22 at the time. It got to be 22 by 2 free. And now that rate is 0.25. If it actually is 0, but I'm going to put 0.25 because people wouldn't believe me if I said 0. And I'll tell you why. Okay? So we'll come back to that question. I think it's in this lecture. Okay. Now, a lower dislocation rate to me is not a big deal because I do, if I do 6 resurfacings a week, I do about 10 regular hips a week, so I do more regular hips. And in the last 5 years, I've had 1 dislocation on a regular hip, and that's over 3,000. So I don't view that as an advantage, but it's an advantage because a lot of people have that. Actually, we're not going to do this slide because I think I'm going through this in the lecture. We're going to go through all these one by one, these advantages. So we talked about conservative on the femoral side. And again, if a patient sees, would I rather have this or this, which do you think they're going to pick? Okay? So it's a little unfair. Which do you want, all these moving parts, or do you want... Now, people are afraid of dislocations. There's a patient that walked into my office 3 years ago. Thank you for this referral from actually somebody in Pennsylvania sent it to Baltimore. They didn't want to deal with that. Bilateral hip dislocations. They both needed operations.
Did he walk?
She's doing fine now. But she needed 2 big operations. Here's Medicare data. This isn't one surgeon. This is 58,000 hip replacements, 4% dislocation rate in the first 26 weeks. For revisions, if it's a second procedure, 14%. Published data. Not opinion, data. Okay? Another study, Mayo Clinic, 20,000 hips, 2% at 1 year. That means you were sitting in a toilet and your hip popped out. Pretty embarrassing, or something like that. It's a very bad complication. People are afraid of that. And then they found that your rate doesn't go down in the first 3 months. You have a 1% chance every 5 years for the rest of your life. So it can go up to 7% at 25 years. So these are, now, I don't want to downgrade hip replacements. I love hip replacements. It's one of the greatest operations in the world. It gets people out of wheelchairs and walking. But you got to, this is some of the scary side. There are problems. This is 4,000 hips, University of Iowa, 7% dislocation rate. So if you can reduce dislocation, here's my series. Well, this is an old slide. But in one group, I think I prepared this for a talk. It's not a big advantage to me because I don't get dislocations, and I don't want to sound arrogant also, rather sound confident, but I got trained by two greats in the field. I come from New York. I went to medical school in University of Pennsylvania. I went to college at Hopkins. I came back to Hopkins and did a fellowship under Dr. Hungerford and Dr. Krakow. They were top people, and they really trained me better than anybody else. And that's part of where I am, having such good mentors, and that's you build on the shoulders of giants. Now, range of motion. This is controversial. I get more range of motion with my resurfacings. Oh, this is a lady. I should have blocked out her face, but she's a ballerina, or she's like my wife likes to do ballet. She's about. So look at this with the hip replacement, and I have a whole crew of ballerinas people that are into ballet that they don't want to get a total hip replacement. They come to me just to get a resurfacing. And I tell people I get more motion with my resurfacings. I get debates in these national meetings. No, they don't get more motion. Well, they get more motion. I would be afraid to get my hip replacement's doing what she does. She puts her leg over her ear.
Oh my God.
Okay. Now, another thing, that's another debatable, but that's debatable. That's my series. Some people don't agree with range of motion. Advantages are they feel more normal. But how would Charlotte know that it feels more normal? She never had a regular hip replacement. How's she going to know that this feels more normal than a regular hip? It's a very hard thing to answer. I can tell because I see the patients every single day, but it's a hard thing to measure. So what we did is we did a gait study. We compared the metal-on-metals to only my patients, same surgeon at 1 year, 13 months follow-up, same approach. I don't know why some of the videos work and some don't. Oh, this fellow is walking. Oh, it doesn't work.
Try loading it again.
Try it again?
Yeah, go back and then go back to the slide. I don't know.
There it is.
Okay, I know what to do. Just push. I know what to do. Foul it up. That's what you do. Let's go back one more time. Picture's really worth 1,000 words, but not when the picture doesn't show. Okay, well this is a picture of, there we go, we can wait here and watch it. This fellow, if I asked you to guess which side his resurfacing is on, you would guess wrong, because he actually has like a little ankle, he had a little bunion or something on his ankle, so you would pick that side, but it would be the other side that had his resurfacing. They look normal at a year when they're doing well, and regular total hip replacements are never normal. So the green, which you can see, is normal in the background. A resurfacing follows that green curve. This is a gait study, hip abduction moment. We have a gait laboratory where I work, and we have 8 cameras that look at how people walk, and we collect the data. It's pretty interesting. The resurfacings appear to follow a normal graph. Total hips are very good, but they don't go to normal in any study ever published. You can always, they're a great thing. And the regular osteoarthritic hip is never normal. But resurfacings approach normal. Now I get a lot of criticism, and this study is being published in about a month or two. I could have brought that, Journal of Arthroplasty.
Did a little girl come through here?
No. But we'll tell you if she does. Okay.
And upstairs
All right.
one of the rooms. Thank you.
Okay. Hope you find her. Yeah, I think we're past that stage now. We have 4 kids from 17 to 11, but that was our life from 5 to 1. That was God. Okay. So the critics of this study are that resurfacing people like you, are much more motivated than my regular hips. And that's why they do so much better than the regular hips. I don't really believe that, because I give the same rehab protocols to my regular hips. And everybody wants to get better. It's not really, I don't agree with that. And I noticed this. It's just a very hard thing for me to quantify. Resurfacings actually do very well. It's also why I wasn't aware of some of the complications, because even the ones that had a fracture, they're doing incredibly well. They would never not get it. They barely know they have a fracture. Another advantage, this is the advantage I like the best if I was considering it for myself. I'm a person that basically I've lived my whole life leaving all my options open, always. Just keep advancing this way and that way, and I like to do things. Resurfacing leaves your options open. You could always go from a resurfacing to a total hip. You just take off the neck. You could leave the cup in and get a hip replacement. You could never go from a big hip replacement back to a resurfacing. You've left that, the option's not there for you. So I sort of like that. Another thing which is very related is if you need a revision of a resurfacing, it's easy, it's straightforward. Cut off the head and neck and just do your hip. A revision of a regular hip replacement, that's hard. And if you don't believe these other advantages, this is an advantage. Now, you could also say though, well, if my hip replacement, my regular hip replacement lasts 30 years, I don't care about the revision. Well, a lot of people in this audience are going to live a lot longer than 30 years. In fact, we met a lady at the Compact Convention, and she told us, I told her she's 70 years old, and I told her, your life expectancy by reaching 70 is about 21 years old. 21 years. Your life expectancy is to live to 91. She said, no way. We got into an argument about this. I thought I was giving her, and no, she likes us. She says, I'm going to live to 106. Absolutely. So she's going to live 33 years, which is twice. It's pretty amazing. Anyway, but that's what she's going to live to. So people want to live longer. You can't expect a lot of regular hip replacements to last 20 or 30 years. Okay. We talked about high activity patients. We have a lot of patients like this. I have patients that I have 2 patients that ran a marathon. I have a few people that bike 50 miles every other day. I have a person that won a judo tournament, a tournament where he had to kick to win at 3 months after the operation, which I didn't allow him. And I have some dancers. No, am I right? We have every sport in the world, and it gets a little bit of a bad name for this reason. Now, I will say that you would be capable of doing all these activities with a resurfacing. Guess what? You'd probably be capable of doing a lot of these activities with a regular hip. Does this mean that Michael Mont or I would really condone this? I do not condone this. I don't know what the effect of running a marathon is on a resurfacing. If I know a person is going to not listen to me and going to run a marathon anyway, they just want this thing, they'll say whatever they can to get their resurfacing and get out of their pain, I'd still rather them have a resurfacing in their body than a regular hip to revise in 6 years. If you're Bo Jackson and you're being paid, at that time he was being paid $6 million a year to play baseball, sure he should get a hip replacement. But not everybody is getting paid $6 million, so I would urge caution on getting a resurfacing and then going back and playing baseball again. You have to decide, is that really worth it to you? Okay? So please don't accuse me of saying you can run that I believe you should run marathons. Now, having said that, I have another twisted logic way of looking at life. If you're going to play softball or singles tennis or doubles tennis, you're going to ski. I don't even condone skiing. I don't even condone skiing for myself. I don't allow our family to do it because I've seen too many. Everybody I knew that skied as I was growing up had accidents. They all tore their ACL just on crazy freak things, and I guess I have a paranoia for that. It's a great sport, but right, Rhonda, we don't let our we don't go skiing. Okay, I guess that's more of my my upbringing. If you're going to ski or you're going to play softball, I don't want people to go and play twice a year, 3 times a year. And I don't want them into 20 sports. So if you really are going to bowl, or you're going to play softball, play a lot. You should be playing 30 times a year. You should develop all your muscles. If you're going to dance, develop the muscles that are specific for that. Don't be a jack of all trades with one of these joint replacements. You want to know what muscles you need to develop to protect your hip. You want to know how to avoid falling, how to avoid being clumsy. If you did fall, how would you fall, or whatever the accident for that particular sport. So that's a little contrary thing. If you really got to pick out something, enjoy the long walk. You can walk 5 or 10 miles on the beach with your spouse, but pick out the 1 or 2 things that you really like and be good at that. But don't try to do every single thing because you're set up for an injury. I used to love softball and baseball. If I were to just go out and pick up a game now, it's summertime, guaranteed I would hit a grounder and I'd try to beat it out and I'd pull a hamstring. Did that twice. Or I would try to make a catch and I'd pull out my shoulder. The only way for me to play baseball now, because I want to win. I have this personality that really drives, and I'm with a bunch of guys and we want to win this game, and I would try to make that catch. The way for me to play baseball is I'd have to start running down the first base line and practicing that, and do that over about 3 or 4 or 5 weeks. Fielding catches, fielding hundreds of balls so that I can play all out. So you got to be very careful, and if you want, and the other thing I tell people, I have a program, let me talk about my rehab program. And I expect people, if you really want to do sports, to do a certain level of conditioning of their hip muscles so that all the weight isn't borne through the prosthesis. And we'll talk about that. Well, let's Let's talk about that now, because I don't know what's coming up in this lecture. The rehab for these resurfacings, the first, you have the operation, you're getting your bearings while you're in the hospital. You're in the hospital for 2 or 3 days. So if you come in on a Monday, you leave on Thursday. If you come in on a Thursday, you leave on Sunday. Some people go home the next day, not too many. 30% may go home the second day after the surgery. We just want to see that your labs are fine. 60% of people in any hip surgery will even have a fever, a low-grade fever, and it just goes away in a few days. The first 5, we've recently changed some of this because a lot of people aren't compliant with the instructions. The first 5 weeks, use a cane or crutch in the opposite hand, which is like 50% weight bearing. And then at 5 weeks, you go to full weight bearing. And at 10 weeks, all the restrictions are lifted. The restrictions are that you shouldn't cross your leg and you shouldn't go past 90. And why do you say don't cross your leg? See if everybody can see me in a chair. When you no, nobody can see me. When you do any hip replacement surgery, you're cutting into the capsule. The capsule is what makes my foot or my hip cannot swivel. The capsule's there as a check ring for any of you sitting there. That's cut out during the surgery, and it has to grow back, and it grows back in the first 10 or 12 weeks. By 10 or 12 weeks, you have a pseudocapsule, so your hip, your leg wouldn't flip 180 degrees around. Now, it's not as simple as that because we reattach everything, but that's why you have precautions the first 10 weeks. You don't want to cross your legs, and you don't want to go past 90 degrees. At 10 weeks, you're unrestricted. Typically, I see people at 5 weeks, and then I see them at 14. Many of them forgo the 5-week visit, just send me an x-ray. The 14 is about 4 weeks after you're unrestricted. And I want to, at that 14-week point, I want to coach somebody into what they need to do for the rest of their life. And what they need to do for the rest of their life is about 20 minutes of hip-specific exercises every other day. And that's it. And it's easy, 20 minutes every other day. It's about an hour a week. Well, if you ask people in a year, 80% of people are just not doing it. Their hips don't hurt. They take their hips for granted. But even if your hip doesn't hurt, you should be doing it because you want your muscles strong. You want to share the load, not just this piece of metal. All things wear. And you never want another hip replacement. You want it to last 30 or 40 years. So that's what I urge that people do. So if you want to do exercises, one of the things I coach is get your strength up of your hip. Get to 10 or 12 and a half pounds through a set of exercises that make sure your hip abductors are super strong. And then at least you're sharing the load with your muscles. You're not just putting all the work on your prosthesis. So anyway, that's a little bit about the rehab of this. And what I want the muscle strength. You start really working on it at 5 weeks after the surgery, right on to 14. And some people run it 4.5 months after. They used to say run it 26 weeks at a half a year, but some people that are really into it, they'll run it 4.5. Some people run earlier, but I think that's foolish. So you want to, at 5 weeks, you want to start working on your strength. You want to get your motion back starting at 10 weeks. Get all the motion for your ballet type of activities. And you certainly want to walk normally. And that's something that you haven't walked normal for all these years. What makes you think you're going to walk perfectly if, for 30 years you've been walking with a limp? So some people, they walk normally in 2 weeks, but other people it could take 6 months to get out 30 years of limp. Yes?
At what point do you think it would be okay to be doing backpacking with, say, about a 40-pound pack?
40 pounds is a strain. It sounds like nothing.
It's a lot.
But 40 pounds to your hip is about 2.5 to 3 times body weight, so it's really like 120 pounds on your hip. So think about that. So I would say if you're not doing the exercises I give people and you're not doing like 7.5 or 10 pounds, depending on male or female, get the strength up of your hip muscles and then go to the pack. Go to your backpacking. But that's perfect example. For you to feel great, I feel great, and put this back, you're putting all the load through your hip joint.
Like maybe 6 months to a year out?
I would say 4.5 to 6 months, depending, no longer than 6 months for most people. There are always outliers. There are people that have had such arthritis for 30 years, it's going to take more than 6 months for them. I mean, I've had people that they took every chart of what I told them to do, and they did it to the T. But they advanced, and then they went, and if they overdid it, they went back, and it took them 9 months to a year. I had one Secret Service agent, 6'7" guy. It took him, he had to run a 7-minute mile to keep going in the Secret Service. He was going to get a revision. It took him a year and a half. He had, since he was 70, he had a bad hip, and he'd come to me every year, and we would inject his hip right before his 7-minute mile. That's a non-operative, and he would do his 7-minute mile, and he had his job. And then he had the resurfacing. It took him a year and a half, and then he got it. No pain, and he beats. I hope he's keeping his hip muscle strong. So count on 4.5 to 6 months to really be doing something like that. Yes.
What do patients do on stairs after surgery?
People do stairs while they're in the hospital. They're trained how to do that. If they have stairs, they do that. That's why. That might keep you. And remember, these are averages. If you really, if I have 80-year-old that are not used to doing stairs, they may stay an extra day or two to learn stairs, or they may even go to a rehab. Some people stay an extra 4 or 5 days on our rehab service, or go to a rehab center if they need coaching in stairs or things. But most people, I believe most people in this audience, you'll be able to do stairs maybe not the first day post-op, but the second day they'll be working on that. Yes?
What if your job requires having left hip?
Those are issues where you'll be able to do it, but do you really want to do that to yourself? And number two, then the jobs start having these medical legal things, because they feel that if you got injured on the job that you would sue them and things like that. And so each of those has to be discussed on an individual basis. My advice, I learned this about 17 years ago. I once did a perfect operation my first year. I've been doing this since '89. And the guy lost his job in '89. He had a perfect hip, but he was a policeman. We're not having him. What if he has to chase after somebody? He can run. And they didn't want the medical legal responsibility. He could not do that, and we never checked that out ahead of time. So when I meet everybody initially I find out what their jobs are. That comes up right off the bat. What are you doing? And it has to be discussed. I mean, you don't want to. I usually tell people, I would rather you be enjoying pounding on your hip on the beach, or with doing the things you're really doing your sport, than pounding it because you have to make a living. So you may have to re-educate that. But do I have people that they're on their they lift 100 pounds all the time. They keep their muscles super strong, and that's what they have to do. They have no choice. I do believe, I shouldn't say it, that some people hide it. They don't have a choice. They have to make a living, and they were trying to get a sedentary type of job, but they can't do it. And they do it. They're capable of doing it, but it's not advisable, because sooner or later that will wear any type of hip replacement out. I can guarantee anybody in this audience pretty much, first of all, I believe that over 95% of the hips I ever have put in will last 20 or 30 or more years. At 10 years, it's over 99% still. Okay, that's a regular hip. But I could almost tell anybody in the audience here, if you wanted to just get a hip replacement and hang around the house and pretty much do nothing, and you keep yourself, you never get an infection or anything like that, it'll last you 40 or 50 years. I would take that bet 99+% of the time. You're sedentary. I'm from New York, and my mother is in her 70s. She's now babysitting for our kids down in Baltimore. She never drove, and she has to walk 10 or 15 miles a day. She goes to the bank and shopping, and she's totally involved does all these activities to keep her mind, she's busier than I am. She would have to get a hip replacement if she had hip arthritis, because she needs to walk 10 or 15, that's her whole life. She's a far cry from the patients I have in Baltimore. Baltimore is a strange city. So I grew up in Manhattan, and now I'm in Baltimore the last 17 years. Everybody in Baltimore gets in their car, even if they had to go 3 blocks. And the typical activity level, they're around their house, and they go out to dinner a lot, 3 or 4 times a week, but they park right in front of the valet parking. They go shopping and hang on a cart, and they have a card game once a week, or a mahjong game or something like that. that's my typical patient in Baltimore area, and I don't believe they definitely don't walk a mile a week if they walk in a month.
Sounds like Dallas.
So they don't, a lot of those, and that's why I could say, when we're talking about non-operative and operative, this is an individual thing. So your question, and you can ask me later, off the record, again, I'll give you my best opinion, but you can't tell somebody when they need a hip replacement and when they don't. Person that has to, their activity level demands 10 or 15 miles a day of walking is a very different than the person that does 10 or 15 feet a day. This person's never going to need a hip replacement. I can keep them from that. This person probably is going to need a hip replacement for the same disease, same pathology. And patients are always asking me, tell me what I need, doctor. But I don't tell patients what, I give them advice. I may tell them what I would do in their shoes if I get to know them. But a lot of people, I haven't gotten to know them. I meet them on a visit and talk for 10 minutes, or I get a big history. But it's got to be you and the audience have to decide what you need for your life. There are very few emergencies. There are occasional emergencies of people that need a hip replacement or need a knee replacement, because if they don't get it, something's going to be worse. But these aren't emergencies.